For those of you that don't know me, I am the CEO of Dental Health Services Victoria, but I come with a background that's a little bit different to some people. I am a dentist originally in training, but then sort of had a bit of a foray out into another world where I went into local government, and then I've been running acute hospitals for about a decade, and then I've come back into dentistry about 2 years ago. And it's a great opportunity to come with very different perspectives than what I left dentistry with. And so some of what I'm talking about today, I'll probably share some of those thoughts with you because I've learnt a lot in that journey. And many of you have got similar experiences, so I will share some of that with you. And I also want to apologise in advance for the fact that, I'm up here giving this lecture, but there's a lot of you here that could probably provide it a lot better than what I do and have had a lot more experience and have been doing a lot of this thinking in this space, more so than what I have. But I'm here, so you get to listen to me, I'm afraid. The first thing I think when we're thinking about the future of oral health is we need to dream a bit, and we need to be imagining all the things that we could possibly be. And the sort of dreaming that we'd like to be able to do, and it's something that right from the very first time I was educated, we were thinking we wanted to be in a situation where people don't have decay, they don't have periodontal disease, they don't have any of those things. So we don't see children having GAs for dental caries. We want to be able to see people that have great behaviours, so they're cleaning their teeth twice a day with a fluoridated toothpaste. They're using fluoridated water. We want to know that restorative care will only be for people like me that were born before fluoride and have now got lots of restorations that need replacement, but that's the only type of restorations that are provided. I'd like to see dentures only being seen in museums. I want people to all have good diets, to drink fluoridated water, not to be drinking all the fizzy drink that they drink at the moment. There's all sorts of dreams that we should have and we should aspire to, and some of the work that we do can actually contribute to that. And they're the sort of things I think we need to be thinking in the public health arena about. What can we do? What should we be doing? What should we be dreaming about? I think as Mick said earlier, we are in a very, very interesting space in the sense that there's a very, very strong national agenda at the moment. And we should each and every one of us, be contributing to that national agenda. At Dental Health Services Victoria, we're very heavily involved in lots of these areas, but in the whole of my career, I have never ever seen so much being discussed and challenged and reviewed at any one point in time. And the sort of examples that I want to talk about is there's a national oral health plan that's being reviewed. We've got one at the moment, and it's drawing to conclusion at the end of this year. And at the moment, there is a whole body of work being done to review the National Oral Health Plan. There is an opportunity to contribute to that with different working groups, and it went live on that website that I've left up there yesterday. So one of the things I would say to you is get involved in developing the National Oral Health Plan. This is an opportunity from a public health perspective for us to have a very big say about the future for the next decade. And so they're the sort of things I think as practitioners in a public health environment we should be doing. We also know there's a National Oral Health Promotion Plan that's been worked on across the country. There's a number of people within this room that have contributed to it, and I understand it sits with the Minister for Health, the Federal Minister for Health at the moment, waiting for a decision about when it progresses. That is a subset of the National Oral Health Plan, but a very significant component as well. There's also a very large body of work being done about workforce. You've probably seen lots of discussions about are there adequate numbers of staff. The ADA obviously have a very strong view about it as well, but we also know there are lots of people in public dental clinics in rural communities that do not have enough staff still and still have trouble recruiting. So it is not fair and equitable, the distribution of practitioners, and there's an opportunity to have something to say about that. And Health Workforce Australia are doing a lot of work looking at anticipating what sort of workforce requirements we have. There's a whole pile of funding requirements or commitments from the Commonwealth that have been announced. The first one is a National Partnership Agreement, which you will have received information from me recently, and that is out there ready for us to start spending a lot of money, which is fantastic, and that's going to significantly improve the number of people that or increase the number of people that we actually see now. There's also the Grow Up Smiling, which is for children, that's due to start in January next year, and then there's another National Partnership Agreement that is being talked about for July next year. I recognise with both those two things we've got an election in between, so anything might happen. But there is certainly a lot of work that's happened with the Grow Up Smiling, which would probably indicate it might happen. And there's also some infrastructure bids that may or may not happen as well. The Dental Board of Australia is undertaking a number of reviews, a scope of practice review, and it's also been reviewing a number of other areas as well. So they're all things that we should, as public practitioners, contribute to significantly. And then there's all the work being done about the national quality standards and how dental interprets that and makes sure that we have really safe quality services provided in both public and private settings. So there's a lot happening on the national stage, and that's a setting we must always contribute to significantly. This is a bit of an old-fashioned statement from a public health perspective, and I know that some of you that have got public health, masters of public health would probably go, that's out of fashion, but it's one of my favourite sayings, and because I've got control of the slide, I've put it up. But it is about, from our perspective, we should be constantly looking at the greatest good for the greatest number. We shouldn't be thinking just about that one individual patient that sits in the chair in front of us. We should be thinking of that whole community that we have to care for, and the people that both come in our front door and the people that don't know that our front door is even open. We have an obligation to those people to be thinking about how we're going to provide those services. Clinicians allocate very scarce resources with every decision that they make, and it's really important that we make the right decisions with the information that we have. Will we do a crown here? Will we hand out a voucher for a denture here? Will we invest a lot of time in a person who isn't looking after their mouth? They're all very important decisions that we make every day, every hour of every day, and they're decisions that make a big difference for all the other people that are out there wanting to receive care. I listen to clinicians talk constantly about the lack of prevention, poor funding models, they're not allowed to do something, and only occasionally do I see clinicians that work with all members of the team to devise a model of care that will improve the oral health for their community. And there are some really good examples of that in public sector dentistry in Victoria. And they're the sort of people that we need to learn from and share ideas from. As individuals, we have very little opportunity, I think, to in fact improve a community. But as a team, and with a very strong model of care, we can do an awful lot. The successes that I seem to see are from agencies that apply very strong public health principles to their decision making and their model of care. They do apply the greatest good for the greatest number philosophies. It took me quite a long time to realise that you couldn't, as a clinician alone, I couldn't make much of a difference. And it took me even longer to realise that maybe the school teacher teaching the kids would have more influence on improving oral health literacy than I ever would. And I've also realised that a maternal and child health nurse will also make a very, very big difference, because in Victoria they see a lot more kids than I will ever see. So these are the people that we need to influence, the people that we need to educate, the people that we need to support, because they are going to make a difference to our community. One thing I find that as clinicians, many people don't always realise that some of these other people are there, or that they can make such a significant difference to our community. Some of us, in fact, some people, in fact, do use these people significantly in improving the health of their community. So sort of the questions that I'd ask when you're looking at the greatest good for the greatest number, are you out there at the moment talking with your local councils who are preparing their municipal public health plans to make sure that it's got good oral health interventions in there, that there's fluoridated water, that there's water bubblers in public places, that whenever the council support any sort of activity, that they'll have appropriate food as part of the policies. So there's all sorts of opportunities there. Are you supporting your local maternal and child health nurses? Do they have the training manual? Do you know about it? Are you supporting them in what they need? So there's a lot of different opportunities there, I think. One of the other key things is minimal intervention dentistry, and I'm not going to go into it in a lot of detail because it's quite clear that, and you'll have different presentations today about it, but it is one thing that I think that we need to talk about. It is really surprising that it's taken so long to really take off. Some people do it and have been doing it for years, and other people are still sort of toying with the whole principle. And I apologise to Hanny a bit for some of my simplification of some of his slides, but I've just put up here what my perception of minimal intervention dentistry is. For me, it's been a concept I've been associated with all my life because one of the first publications ever was from one of my teachers at uni, the late Dr Owen Makinson, who, if any of you knew him, and some people in this room did know him, he was a fixed prosthodontist. He terrorised students for decades, and we were all terrified of him. And we all thought he had gone slightly mad when he started advocating a minimal intervention dentistry philosophy. And yet now there's a lot of evidence that supports that. He produced, I think, the first body of evidence to support that, but we seriously did think he was crazy. But we now know that, I mean, you even now go to I went to the last ADA National Conference here in Melbourne, and they had a lot of things on MID. In fact, probably a third to a half of the program was on MID, which was fantastic. The other half was on implants and aesthetic dentistry, so we can't get it all right, but at least it's heading in the right direction. I also have a view that the MID concept should apply to all of dentistry. I know that it's normally just about caries, but it could also apply to perio, it can apply to prosthetics, the use of prosthetics. It should apply in all of those basic principles of making sure that you risk assess, you do the use prevention wherever you can and minimal intervention whenever you can. We want to use the least destructive techniques that we possibly can in any place. So MID is not a solo job, it's actually a job that applies to a team. You can't do it by yourself, you need everybody to be involved, right from the person that works in the front door or is at the front door right through to the people that are out in the community supporting the people living and working and playing. The other thing too, and I also won't go into a lot of detail, are the social determinants of health. I think we have to recognise the fact, and most of you here do, is that the drilling and filling isn't going to make the difference. It's all the environment that the person sits within. And I know Shalika will be talking a little bit later today or this morning about that. But this is sort of an area I'm quite passionate about. On Thursday night, I'm going to be braving the cold by sleeping out in the CEO sleep out. And it's pretty cold and wet at the moment. But in the process, I've been doing a bit of research to try and work out what I'm up for. And I get dinner which is a soup out of the soup kitchen with a bread roll and some soup. I get 2 pieces of cardboard and I'm allowed to take a sleeping bag and a pillow. My kids have already told me that most people that sleep out don't have a goose down sleeping bag. So I'm already up for it. I'm a bit worried about whether I'll be able to sleep at all. I will be in an enclosed, safe environment in Etihad Stadium. I won't be out there worrying about whether I'm going to get mugged, raped, all my stuff taken away from me at all, which is what the daily lives of a lot of people out on the streets are. So, and I think about these people that you deal with every day and think, would they even worry about whether they've cleaned their teeth or whether they've got good oral hygiene techniques or not? No. Do they have access to toothbrushes or toothpaste? No. There's a lot of people out there that have got a lot of other things to worry about than worrying about whether they've got beautiful oral hygiene. And I suppose for us, one of the things we've got a challenge for is how can we help them to at least take that away as being one of the problems that they have. So there's lots of opportunity. It's not easy, I know, but it is a hard situation to do. But we do need to be thinking about smarter ways of helping people like that. And there's lots of other disadvantaged groups in our community that also have similar sort of issues that are quite particular to them. So with the social determinants of health, there are a number of opportunities that we have here. These are the 5 sort of things from the Ottawa Charter that you would use as, I suppose, the basic themes that you would use for designing ways of dealing with those social determinants. And I think when we think of the examples, building healthy public policy, we'd be thinking of fluoridated water and the support that we can give for that. Creating supportive environments. That would be the sort of Smiles for Miles type campaigns that we use in childcare centres, etc. Maternal and child health nurses programs and the support that they have for their checks at ages and stages. The strengthening community action, that's working with Foundation House and helping refugees and asylum seekers with their model of care and the treatment that we provide. And developing personal skills, that's where we might be working with midwives, training them to hand-on knowledge to pregnant women and to diabetes educators for people that have got diabetes. So there's quite a lot of opportunities that we have there that we can actually influence rather than the drilling and filling, but can assist other people. One of my pet loves also is a model of care. I have a very strong view that we need to document the types of the model of care that we are going to provide. A public model of care is different to a private one, and it's something that we should be very proud of, but we also need to have a set of principles by which we're going to provide services. A lot of people here have started writing or are well down the track of developing models of care, and at the dental hospital we're starting that process as well. Everywhere you go in health, people will talk about models of care, and I think we're a little bit behind in that in public dentistry, but it's something that we need to do. We need to have a model of care because that's how we design our workforce, it's how we build our buildings, it's how we determine what services we're going to provide, what clinical guidelines we need, etc. And so we need to actually spend some time documenting the types of things that we do we need to do for a model of care. So we'd have things like, we need a set of principles about we're going to have a preventive-based model, or we're going to be family-centred. There's a number of things that we will look at and determine. So with the model of care, we need to have a number of goals, and some of these reflect some of the goals that we would have. So we want to actually improve oral health with the types of services we provide in the model of care. We want to use best practice, we want evidence-based, etc. And we actually want to have positive impacts. It's all fairly straightforward, but sometimes documenting them forces you into reviewing the types of services you actually provide and determining are they appropriate or not. So the way forward, there's a lot of opportunities there. One of the things that Mick talked about a little bit earlier was that over 30% of our population are eligible in Victoria and Australia are eligible for care in the public sector. Of that 30%, we see 14% We're not even touching the sides. We've got all this extra money coming in from the Commonwealth. There's an opportunity for us to be really smart about how we do it and use that money. And I think this is a real opportunity that we haven't had for a long time. People on average wait about 17 months for general dental care and 18 months for dentures. We have an opportunity to change that. So there's lots of things that we can address. We can see more children, we can make sure that they get regular calls, we can utilise a minimal intervention dentistry philosophies about providing services to our communities. So we do need to look at our model of care. We do need to develop it, adjust it, or review it if we've got one. And we need to examine our clinical practices and determine that they are the appropriate ones for our communities. I've already talked to you about the National Partnership Agreement that's just been signed off between the federal and the state government. It is up to 85 million that we can spend up through till March 2015. It will treat about an additional 110,000 people. It's a lot of people, and that's right throughout the state, but it does present a great opportunity. One of the things that is very important about that opportunity, though, it is a fee-for-service type model, and from a public health perspective, I'm not necessarily supportive of fee-for-service models, but that's what we have, so we work with it. But one of the things we do need to do is to make sure that we keep achieving the maintenance of effort of work that we've done in the past, so we're talking about keeping our baseline going, and we also need to then do this extra activity, quite a significant amount of extra activity, that will be based on item numbers. And so I really urge everybody in the audience to make sure that you are recording everything, because in our last funding model that we're just about to close up with the Dove funding model, we noticed that lots of people stopped recording item numbers, and so there's been a fairly significant drop-off. So I'd really implore people, if you've done it, record it. It's really important because that's how the funding will come about. And if we get the funding, we can do some of the innovations that we need to do in our model of care. So from my perspective, what does success look like? Well, I would have an imagination that we would be treating at least half of our eligible population, which would be fantastic. We would triage people appropriately and make sure that we put them on, if we put them onto waiting lists, we make sure that we manage them while they're on the waiting list. We don't just leave them there to get worse. We won't have people going to EDs and GPs for inappropriate care. We will actually treat them for dental care, and they will come to us because they know that we exist. And that we find that disadvantaged people won't have a different oral health status than their more advantaged neighbours. So I think there's a real opportunity for us to be very successful in this near future, and it's up to us to actually change the whole agenda and the way we've done things. So it is a time for us to be able to dream, and I think it's really important that we do actually think and intellectually challenge ourselves about how we're actually going to breed this success.